Okay. Abdullah, thank you always for giving me the chance. I was trying to give this talk before COVID, but unfortunately COVID came. And are you counting my time? Sorry. Then this is not fair, Abdullah. Please go back to 15. Thank you. Look, you know, I will go really quickly, but please ask questions when we have question and answer, because this topic to be covered might need 45 minutes, 1 hour. So I just want to go quickly whether stem cell therapy, is it a medical breakthrough or it's gone, it's a dead end? That's me. So we'll talk about the past, the present, and the future of stem cell therapy in heart failure, and whether it is successful in improving various parameters in heart failure patients or in cardiology in general. But today I will focus on heart failure only. There are 8 indications of stem cell therapy in heart disease. One of them is heart failure. So before talking about stem cell, do we really have endogenous cardiac regeneration? The answer, look, for more than 50 years, people think the heart does not regenerate itself. It's like an end organ. However, with the discovery or with the use of stem cell therapy now, we know 100% the heart can regenerate. It is very slow. The rate of regeneration is like 0.5 to 1% per year, which is very slow and is not enough. And that's why we have the poor prognosis of heart failure with medications or without medication. Now, what are the potential source of cardiomyocyte regeneration? How the heart cell regenerates? So these are the 3 potential sources. There are a pre-existing cardiomyocyte, which they are present in the heart, and they can de-differentiate. They become like embryonic stem cell, and then they can proliferate. There are resident cardiac stem cells, which are already present. People have done many cardiac biopsy. We have cardiac stem cells there. And we have extracardiac progenitor cells. They are present in the adipose tissue and in the bone marrow, and they can move to the site of injury to the heart to help for regeneration. All these 3, we have evidence for that. So let's go to the results of the clinical trials of heart failure, and today I will focus on HFrEF, because with PEF we have very limited studies, but we have more than 300 phase 2, phase 1, 2, and 3 trials on heart failure since 2002. So it's a lot of studies there, and we will go for the type of cell, because we do have plenty of stem cells, and each trial use different. It's like using beta blocker, ACE inhibitor, and RAS, and all these things. So these are the clinical trials, which I go through them very quickly. You could see on the left is the type of the cells, the name of the study, and the number of patients. You could see the number compared to clinical trial in heart failure is not tremendous, but that's when it started, 2002. 6 patients, 10 patients, 121 patients, 191 patients. And on the right side, you could see almost all the trials are positive in terms of improving the ejection fraction, improving the symptoms of the patient, and systolic volume and diastolic volume, and so on. Most of the trials. Now, we do have in this column a meta-analysis of 1,907 patients, and the result with that showed there is an evidence that bone marrow mononuclear cells reduce mortality, improve ejection fraction, and improve NIHA functional class. This is another also meta-analysis of 29 studies, which showed improvement in left ventricular ejection fraction, NIHA, and volumes. Now, this slide showing you, I don't have a pointer, but it looks like, if you look on the left side, safety, this slide showed all the stem cells are safe. In fact, stem cells are the safest medicine on the planet. So they are not drugs, by the way, so don't mix, but they are the safest medicine used in the planet. Yeah. Okay. But this will waste a lot of time, no? I'm short of that. I'm really running. Now, exosome, I will go quickly. Exosome is a microvesicle secreted by the stem cell. And there are billions and billions of exosome secreted from the stem cell. Actually, the exosome are the message. If you have two phones and you use WhatsApp, there is no use of WhatsApp unless you send a message. So the message is the exosome. The exosome carries all the functions of the stem cell. So the future maybe we don't need stem cell. We can extract their exosome and inject it intravenous, and it can do the job. There are a few preclinical studies on exosome, but there is on animal studies. Okay. So what is the function of the exosome? Why we use them? Now, there is a clear evidence. They show cellular viability, anti-inflammatory, immunomodulatory effect, support neoangiogenesis and cellular proliferation. And there is an interesting concept in stem cell is the homing effect. The stem cell, when you inject, is looking for a home. The home is any injured tissue in the body that it stimulates by a secretion of a lot of cytokines from the injured part, and also talking with the exosome from the stem cell and a lot of factors secreted by stem cell. So there is called homing effect. The exosome, they have the homing effect of the stem cell itself. So what is the advantage of exosome over stem cells? Number one, there is lack of inherited risk-associated cell-based therapy because people think this is, allogenic sort. It might cause like reaction. Lack of potential of theoretical malignant transformation, and I will talk about that if you ask me. The lack of immunogenic response and targeted action at the site of interest. They are much, much smaller size, so there is no fear of the theoretical risk of blocking the small capillaries by the stem cells. So, do we have limitation of stem cells in treatment of heart failure? The answer is yes, but we can overcome that. So, number one, let's talk about cell types. So far, we don't have a type of cell that has met all of these expectations in clinical trials. But most of the studies showed mesenchymal stem cells, which we can talk about it later. They are easily isolated from the fat or from the bone marrow. They are easily expanded and cultured and injected. They are multipotent cells. They can differentiate into most of the cells in the body, including the cardiomyocyte. Low immunogenicity. They don't have HLA antigen, so there is no reaction. And they have a paracrine potential, which is secreting of factor that affect any cells in the injured part of the body. There is one cell type called induced pluripotent stem cells, which I will show you some slides if the time allows. Now, how this works? Can you help me, please? This slide, this should be a video. Technology failed. He promised me it will work. See how much I lost. Can you freeze the time? Okay, yeah, now. I will show you when we have, not time, during the time of discussion, I need to see these slides, because this is the real work which has been done, and they got a Nobel Prize for that. A cell taken from the skin, just a fibroblast, taken into the lab, given 4 transcription factor, changed into heart muscle beating in the dish. So I have few examples of that, and the same cells are given to a guinea pig heart, like a scaffold, and I will show you that the heart muscle of the pig beating at the same time with a normal ECG, no arrhythmia with the injected cell. So please give me time to show that later. 1, 2, 3. Now, this is an example which is not video. This is a monkey. They ligated the LAD and developed myocardial infarction. You could see the blue is the fibrous tissue. The other type of group of monkeys given direct coronary injection of cardiac stem cells. And you could see the green part of the other monkeys, it's all cardiomyocyte. So they grew a heart muscle in the monkey heart post-myocardial infarction. Now, the dose of stem cells still, we don't know the dose. Many of the trials showed the range is between 100 million to 200 million. Oh my God, 3 minutes left. So we have issues of cell retention when you give intracoronary and engraftment of the cells, the survival and the rejection, and we have solution for that. The route of administration, it started by cardiac surgeon, so it was open heart surgery, then intracoronary, then subendocardial injection, and currently we give intravenous infusion. Patient characteristic is very important. Old patient is different from young patient because we use your own stem cells, and the minute you go older, the cells getting a bit sicker and weaker. Combination therapy nowadays is combining 2 or 3 types of stem cells because each type of stem cell carry a different function. And let me rush. Growth factor, I will not talk. Conclusion. Now, many important questions still remain as our knowledge is limited about the following. Now, do we need to focus on the cells or on the cell product? So that's another thing going on. What is the effective type of stem cell? Still we need to know. What is the ideal dose of stem cell therapy? What is the best route of administration of stem cell? And now the cardiologists are divided into 2 groups. The first group, do we need to do stem cell therapy to increase the retention with a scaffold so that the cells will stay in the myocardium? Or we don't need the stem cell, we give the growth factor of the stem cell and inject it intravenously if it is doing the job. In the setting of heart failure, the result of cell therapy trials are more encouraging, both in the setting of ischemic and non-ischemic cardiomyopathy. These are, I'll give you 6 examples of the very significantly positive trials. We have MS heart failure, cell DCM, regenerative DCM, concert trial, BAMI, and the best trial which we have is phase 3 DREAM heart failure trial, which was published, actually presented in American Heart Association last year. And if there is time, the DREAM heart failure is more than 600 patients given subendocardial injection of stem cell therapy. And there was 60% reduction in non-fatal ischemic major cardiac events, which include myocardial infarction or stroke, and reduction in, especially in class 2 patient, cardiovascular mortality. I'm not sure if any trial has shown 60% reduction in cardiovascular mortality. And especially if in non-ischemic cardiomyopathy, if the CRP is high, the MACE was reduced by 79% compared to placebo. This is very, very significant reduction. Abdullah is there, okay. Okay. This is the future. A stem buck instead of Starbucks, where you can drive through, get your stem cell therapy. If you need a double shot, you can acquire it, and it should not be a dream. Thank you very much.
Always start as a